mynews.studio.
Picture a child squinting into the sunlight in a dusty village. The question is, can we finally end infectious blindness within our lifetime?
For context, today is February 21st, 2026. Let's start with some numbers. Back in 2002, about 1.5 billion people were at risk for trachoma, which is the leading infectious cause of blindness. That's a huge part of the global population.
Yes, and trachoma is more than just a figure. It's a disease that spreads through eye and nasal discharge, contaminated items, or even by flies. It thrives in places where there's overcrowding and not enough access to clean water or sanitation. Women and children are most affected, especially since mothers caring for sick children often get infected themselves.
The disease process itself is harsh. If someone is repeatedly infected, the upper eyelid gets scarred, which causes the eyelashes to turn inward and scratch the eye. That's called trachomatous trichiasis, and it leads to permanent blindness. Why did it take so long to bring this under control, even though we understood the cause?
There were a lot of obstacles: poverty, lack of infrastructure, limited access to healthcare, just to name a few. But things shifted in the 1990s when the World Health Organization introduced the SAFE strategy. That stands for surgery, antibiotics, facial cleanliness, and environmental improvement. But what really tipped the balance?
Azithromycin made a huge impact. The antibiotic was donated on a massive scale. Over 1.1 billion doses were distributed. Organizations like the International Trachoma Initiative and the Fred Hollows Foundation played a big part. Combining mass drug administration with targeted surgeries and improved hygiene really reduced the disease burden.
And data collection was crucial. Projects like the Global Trachoma Mapping Project and later Tropical Data Surveys gave teams the information they needed to act precisely. Before that, it was almost impossible to know where the need was greatest. How would you allocate resources without reliable data?
Right, that's a fundamental point. This targeted approach led to a 94% drop, from 1.5 billion people at risk in 2002 to fewer than 100 million by the end of 2025. In public health terms, that's a huge shift.
But the heart of the story is in those communities. Children between 1 and 9 years old are the main carriers, and women, because they care for children, are both at higher risk and key players in fighting the disease. Campaigns focusing on hygiene, facial cleanliness, and community education have turned those most at risk into leaders for change.
Even so, the job isn't finished. Most of the remaining cases are in Africa. Over 100 million people at risk across 30 countries. What are the main challenges now?
Funding gaps, weak infrastructure, and sometimes a lack of political will. If those aren't addressed, there's a risk of losing ground. The costs of blindness go beyond health. They include lost productivity and extra healthcare needs, especially in already disadvantaged areas.
Still, it's a milestone for global health. Collaboration between countries, pharmaceutical donations, and a strong focus on data have brought us close to eliminating a disease that's affected people for centuries. Could this approach work for other neglected tropical diseases?
It shows what's possible with consistent effort, smart data use, and strong community involvement. Preventing millions of cases of blindness improves lives and economies. The same lessons could help in other areas if there's enough commitment.
So what happens next? Will the world provide the last push needed, or will we see progress stall?
That's the key question. We're close to the finish line, but it's not guaranteed. Ongoing vigilance, funding, and community action are all still necessary.
We began with the image of a child blinking in sunlight. Now, millions may soon live in a world where blindness from trachoma is only a memory.
Thank you for joining us. This episode was brought to you by mynews.studio. You can try it now, free of charge.